All right, so without further ado, I'd like to introduce Dr. Clementina La Rosa. She's an endocrinologist and she works with women of all ages, but tonight she's going to be focusing for our purposes on the menopause transition and the use of hormones in that. So Clementina, take it away. I will in fact mute myself.
Good afternoon. So my name is Clement. Can you hear me well? Yeah, can you hear me? Good. Yes, very nice to meet you all. My name is Clementina La Rosa. I'm a specialist in endocrinology. I'm a specialist in pediatrics and endocrinology, and I work in London under the Department of Endocrinology and Reproductive Medicine unit of the University College Hospital. So yes, this is the hospital now, and this is the hospital when I used to work there in 2002. Now we have a completely brand new building. I felt sorry when they knocked it down, but anyway. So yes, as Tracy said, I look after, I had this privilege of really looking after women of all ages, but at the moment I am more focusing on adult or young adult or adult women. So I thought that tonight we could cover the topic of perimenopause transition and the use of bioidentical hormonal replacement. I am a doctor, so I will cover the current medical concept, the hormonal, the typical hormonal experience, the typical hormonal change and experience change that happen to women. If the diagnosis of perimenopause is possible to be done when women have normal regular periods, and how can we effectively address symptoms. So I thought that we could really start talking about timeline and definition, because sometimes there is a little bit of confusion between about the concept of perimenopause and premenopause. Sorry, there is a spelling mistake. So basically, premenopause and perimenopause very often are used interchangeably, but they actually define two different times in life for women. So pre means before the menopause. It is actually the time from the moment period start, so from menarche, up to the time of the perimenopause. Perimenopause, it means, peri means around, is the time before, around the menopause. So few years before and few years after the menopause, when and is typically characterized by intense hormonal fluctuation, especially at the very beginning. So generally healthcare professionals do use the word of perimenopause, and they do refer to the time around menopause. And menopause is doctors call menopause that phase when period have stopped for at least 12 months. So I really think that what is important to understand for women is that this is a really new phase of life. In the past, when I was at university, very little was known about this phase of life, and it was really associated to this idea of decline, health decline, or decline of life. But for me, it's actually a completely new phase of life. We are maturing beyond our reproductive years, but this is a really important opportunity for women to really take charge of their hormonal health and understand how to manage their health. So I thought, sorry about that. Okay, we need, unfortunately, to understand what happened, we need to start from the basic. We need to start from really baseline, and this is a slide really showing what happened to these ovaries. So, and what happened to the ovarian pool. So women are born with a fixed number of eggs. Women, as we know, women are not making eggs throughout life. They are born with a fixed number of eggs, and then this pool get gradually decreasing. So in prenatal life, it is a maximum. There are about 3 million of eggs, and they are gradually declining to critically low numbers up to the age of 50. Yeah. Oh, sorry. So this decline in the primordial follicle pools, so the decline in the eggs pool, is associated to an increase of a hormone called the FSH. I'm sorry, can you, this blue line is the FSH, and this is the hormone, the fertility hormone that the doctor generally check to women when they complain of symptoms of perimenopause. Generally, highest FSH is linked to perimenopause. But as you can see, there is an intense fluctuation just after the age of 30. So if you do a blood test, for example, at this time, you may pick up a normal FSH, and then after maybe the following day, it would have gone up. And this is really a very intricate slide that I wanted to show you, not for the purpose of the slide itself, but really it is about, I'm not sure if you can see in your screen. So this paper was the first published, was the first paper documenting the stages of reproductive aging in women. And it was published in 2001. So just 20 years ago. Before that, nobody knew anything about, I mean, nobody were really describing this problem. And then, of course, they divided the stage of reproductive aging in different phases. It's a very, they talked about the reproductive life, menopausal transition, and post-menopause. And this is also associated to hormonal and physical change. But I think that there is a much easier slide to understand that this one that has been published by Professor Pryor in 2001, and Professor Pryor is one of the pioneers on the topic. And she described, so on the top here, you have perimenopause. So perimenopause is the period that could last really up to 8 years. So from the final menstruation, is 3 years plus 2 to 5 years, so could be around 8 years. And it is characterized by a very first phase, that this is called the early perimenopause, where women do experience symptoms, but they do have regular cycles. And maybe they can present also some hormonal fluctuation in sex hormone levels, but mainly they are symptomatic. But they go to the doctor, they have regular periods, they do a blood test, the hormones are fine, and everything is fine. And I think this is the most frustrating time for women, because they are feeling unwell, but they can't have an answer. Following that, there is another phase that Professor Pryor called the early menopause transition. And this is when periods do change in duration. They could be shorter, they could be longer. So here you have symptoms, you have differences in period duration, but still you have hormonal fluctuation that are not always identifiable. And then you have late perimenopause, and this is the time where women do start skipping periods. And again, they're symptomatic, but now we have the skipping period that could be like a proof that they're going through perimenopause. We have the final menstruation, and then, as I said, 12 months after 12 months of lack of period, the doctor will tell you, okay, you are in menopause. So This is again to summarize what I just said. Early perimenopause is several years of change in quality of life without any cycle interval, and the hormonal levels could change. But as I said, they could change, but they're not always easy to be detected. Early menopause transition has a cycle variability, so around 6 to 10 years to 10 days shorter or longer. And late menopause is late menopause transition when we start skipping periods. Okay, so I'm just to mention a typical case of a 41-year-old woman, office manager, mother of 2 teenagers. She presents with flooding menstruation and dizziness, night sweats, and breast tension. And I think this is really the typical case where things that start conventionally don't make sense, because you think, okay, she's complaining of night sweats, which is a sign of low estrogen, but still she's presenting with flooding menstruation, breast tension, which is a sign of high estrogen. So what's going on? And I think this is the very first evidence that has triggered lots of investigation from that triggered all the material that Professor Pryor has published. So this graph, this figure, really is just taken from the internet, and it tells you what we all know. So we have the estrogen that with the light green, this area here, they start increasing up to mid-cycle under the effect of a hormone called the FSH. Then they trigger a LH peak, which is another hormone that triggers ovulation, and then they fall down, and after estrogen falls, there is a progesterone rise. Okay, but I just wanted to show you more. This is another beautiful picture, again displaying the same phenomenon. It's come from Professor Conway, who was my mentor, a PCOS handbook that has been published in 2017. And it's the same graph, and on the top, it really explains the change in womb line, in the lining of the womb following this hormonal change, and the change in the ovarian follicles. So you have the follicles that is maturing, releasing an egg, and then becoming atresia. So basically dying. But what is interesting is that if we replot the estrogen and the progesterone curve according to how the percentage the percentage they change from baseline, we found a completely different line, which is this one. I'm not sure if you can see. So this is the estrogen, and this is the progesterone. So you can see that estrogen from baseline increases up to 240%, but progesterone from baseline will increase up to 1400%. And why is that? It's because the unit of the measurement, the unit range is different. Estrogen are measured in picomoles, and progesterone is measured in nanomoles, and nanomoles is 1,000-fold bigger than picomoles. So that means that in the ovarian cycle, in order to kind of create this effect on the womb lining, the amount of progesterone we need to balance estrogen is much more. So you need this area around the curve of progesterone to balance this little estrogen. And this is, I think, this is quite important to understand when we are then addressing perimenopause with the hormonal treatment, and I'll tell you why. Okay, so I'll give you a little bit of physiology again. Here will be very quick. These are 2 ovaries. full of eggs. What happened during the cycle? During the normal ovarian cycle, every month, the brain will produce hormones called FSH, a hormone called FSH, which is the one I showed you at the beginning. The doctor will measure when they want to know if you're menopausal. This is the one. I can't. Anyway, FSH. I'm not sure why here we go. FSH. FSH will stimulate the ovary to grow follicles. The ovary will, some follicles will start becoming bigger, and then there will be a predominant follicles that will become the biggest and will start making estrogen, because estrogen comes from the follicle. And at that point, the ovary generally send a signal to the brain to say, lots of estrogen already around, switch off this FSH. And this signal has now been identified under the name of inhibin, which is a protein that is produced by the ovaries and has the role to switch off this feedback. And at that time, so you got to one follicle maturing, reaching a decent size and making estrogen, inhibin get released, and inhibin will switch off FSH, and everything is done. But what happened in perimenopause? We do really, now it is clear, the idea that with aging, the ovary will make less inhibin. Therefore, there will be less signal from the ovary to the brain to switch off the FSH. So the FSH will start pulsing, and so more than one follicle will start growing. And that's why, so you have lower inhibin levels to allow an increase in this FSH. The FSH will stimulate a larger than normal number of ovarian follicles, and each of them will produce more estrogen. And then you have, so therefore you have more than one follicle to mature. And this is why older women have a higher probability of non-identical twins pregnancies, because there may be more than one follicle growing within a cycle. And this is also, of course, linked to a production of more estrogen that will translate in these PMS symptoms, so flooding periods and tender breast. And this is what we were just discussing with Tracy. It's a really nice comparison that I heard at one of the lectures from Professor Pryor. She compares the perimenopause to the ovary grand finale, where the ovaries will really have to, it's a blast at the end. Again, really trying to explain what happened in the ovaries. The boom, boom, boom will make lots of follicles. Okay, this picture again is another study that is displaying that all the women, in all the women, the mid-cycle estrogen peak is higher, so you have a higher estrogen. And those are other studies that have shown, so if you compare, so this very first one is about estrogen, E1 is estrogen. I think these are, because this was done with urinary estrogen metabolite. So perimenopausal women do excrete more estrogen than non-perimenopausal women. They have you see there, and the curve is is bigger. Interestingly enough, perimenopausal women seems to have a lower progesterone than the menopausal women. So what you see in perimenopause, especially at the beginning, early perimenopause, you see higher estrogen and lower progesterone. And again, it's very, I really wanted to highlight that, because that's what you try to address when you want to establish treatment with HRT. So, okay, so in summary, I said that there is a dysregulated estrogen peak that is not inducing a LH peak. Okay, no, there is no ovulation. There's a dysregulated LH and estrogen peak that will induce no ovulation. We don't have FSH suppression, so the FSH will start pulsing because there is no inhibit. And we have an elevated estrogen that not counterbalanced by ovulatory progesterone. I would skip this because it's just what I just said. So is it possible to make a diagnosis on the basis of symptoms? Yes, it is possible. And a diagnosis of early perimenopause can be made in midlife on women who continue to have regular flow if they are experiencing any 3 of these 9 symptoms. So heavy period, shortened menstrual cycle, swollen or lumpy breast, disturbed sleep, increased cramps, night sweats, migraine or headache, which is a sign of low progesterone, mood swings, and weight gain without any change in diet or exercise. And what is happening now? Okay. Okay, so what I've just described before, it was the early menopause transition. Then we have the late menopause transition. And here, as we said, we have skipped cycles. The breast tension is lower. The heavy flow may be lower. And so those symptoms improve, but women are more affected by hot flashes, sleep problems, and I would also say intense mood fluctuation. At this stage, I would say the estrogen is not, we don't see the same amount of estrogen increase that we see at the beginning. Okay. So how do we manage that medically? We use hormonal replacement. And then everyone has a different style, of course. What I do in my practice, I try to correct the physiology that I've just described. Therefore, in perimenopause, I try to correct progesterone that we saw lower than estrogen and much lower than what we saw in that graph that was explaining how much progesterone we need to balance a little bit of estrogen. In late perimenopause, we may need the help of estrogen because some women may really drop estrogen, so they will need estrogen and progesterone together. And then at some point, we can also consider the use of testosterone or DHEA, which is not really the topic of this presentation, but I will mention at the end. The management has to be, in my opinion, multidisciplinary. There are many health professionals involved in the health in correcting. I mean, when women are really unwell, it's not only the endocrinologist with hormonal replacement. There are lots of other professionals that may get involved with physical physical work, for example, osteopathy. Some women need psychology intervention because the mood is really low. Nutrition is fundamental. Correcting through nutrition, correcting the high amount of estrogen is also extremely important because there are ways, as I'm sure you have covered with Tracy, there are ways to balance this amount of estrogen even through lifestyle. Support groups are important. Sharing experience, talking about what is happening to you, what other people have found useful, and understanding that we are not alone in this we are, or is happening to all of us. And then, as I said, always individualized care. We all different. We all different. We all going through different paths. Certain women do respond really well to progesterone, other women do not. Certain women do well on oral progesterone, others need vaginal progesterone. And sometimes you have really to consider, after appropriate information, the use of not preparation that are not formally recognized. As I said, the HRT must be individualized and tailored according to symptoms, family history, results of investigation, and women preference. And I would say also psychosocial element. Once you start HRT, it's always important to reassess and re-stratify the risk. So it's not only about starting HRT. What some people do, they go to the doctor, they get HRT, and then forget about the doctor, carry on, and maybe the GP will give them a repeat prescription, they will carry on forever. No, it doesn't work like this. You need to see the doctor, you need to reassess your situation, reassess your risks, because everything comes with a little bit of risk. And how do you make this reassessment? You do use bloods, pelvic ultrasound for evaluation of the lining of the womb, because that responds to estrogen. And you also, at this age, you also need to be up to date with the breast screen, with breast surveillance. Right, okay, so what do we do? Shall we, is anyone asked, what shall we do? Because I think I said quite a lot. Do you want to do a break and ask questions, or you want to go till the end and then we do questions at the end?
How's everybody feeling?
Maybe questions at the end so that we don't ask what may be covered.
Okay, question at the end. Okay, no, I feel that that's covering maybe too much. Okay, so what do we do? As doctors, what do we do? Progesterone, in the perimenopause, we use progesterone. Progesterone is required for all women, especially women that didn't undergo hysterectomy. Progesterone can be prescribed cycling or continuously. There's quite a lot of evidence on the importance of starting continuous progesterone at some point, at a specific stage, because it's considered safe and important for breast protection. Now we really know that there's a progesterone called the micronized progesterone, and this is bioidentical progesterone that is now in England. It is possible to be prescribed under the National Health Service. I believe it's the same in America. But it's progesterone, macronized progesterone, bioidentical progesterone, that is generally prescribed orally, so in tablet or vaginally. Some women do use Mirena coil for contraception. It is important to this is an intrauterine device that is releasing a progestogen to protect the lining of the womb, because when the estrogen do stimulate the proliferation of lining of the womb, whereas and progesterone would control this stimulation. So would avoid that the lining becomes too thick, because thick lining of the womb is an increased cancer risk. So I think, my job very often is making sure that when I prescribe HRT, this lining is under control. So certain women do prefer not to take progesterone orally, and they just want to protect the endometrium, and that they would use Mirena, the coil. But what is important to clarify, Mirena doesn't release natural progesterone. It does release another compound that is called the progestogen, so similar to progesterone, but is not progesterone. Generally, women that are intolerant to progesterone are advised to take Mirena because they think that if we just cover the womb, it won't go into circulation. But actually, I have to say there is a minority who would get progestogen effect still. So I wouldn't exclude 100% that is a local progesterone effect, because there's still quite a lot of evidence that say that a little bit could get absorbed and go into the circulation. But as I said, individualized care, and some women that do not do well with progesterone have to take only Mirena, although it's not my favorite option. Now, transdermal progesterone, it's progesterone cream. Some doctors do prescribe it. I do not prescribe it. And the reason why I do not prescribe it is because it's very difficult. It's not really very well absorbed, and therefore the endometrial protection of transdermal progesterone is not effective. The other thing is how do you monitor progesterone once you start the treatment? Generally, clinical monitoring is very effective. So you monitor the symptoms. If someone is reporting to feel better on progesterone, that's already an indication that is working well. Otherwise, you do a blood test or you do a urine test, or you like the Dutch, for example, and you can measure if you are in a therapeutic range of progesterone. Saliva progesterone, unfortunately, is not the gold standard. It's very difficult to assess if you're in a therapeutic range through saliva progesterone. Lots of studies have confirmed it. With regard to HRT, unfortunately, we do not have data available. So as I said, it's an individualized care. Women have to be counseled about those these elements as well. But again, in some cases, with the appropriate documentation, some women want to take compounded formulations. This is what I just said. What is a progestogen? A progestogen is a compound that is similar to progesterone, but is not progesterone. It goes and interacts with progesterone receptors, but is not progesterone. And there has been some concern about a very small increase in breast cancer risk on women taking HRT containing these progestogens. So I'm not sure if you ever heard about that. They're called noretisterone. Sometimes they are together with the standard HRT preparation. So standard HRT preparation may contain a natural estrogen and one of those progestogens. When they contain one of those progestogens, they're not totally bioidentical. So you have those progestogens that come from noretisterone, which is a stronger progestogen, and they're called the noretisterone, levonorgestrel, desogestogel, gestodin, and dinogest. Those are but sometimes you find this in the oral contraceptive preparation. And then there are progestogens that derive from natural progesterone, but they're still progestogen. So yes, now this is again another, there's a consensus, there's a statement from the American Association of Clinical Endocrinologists, American College of Endocrinologists in the meeting Menopause Update in 2017. And the statement is that when the use of progesterone is necessary, and I would say that is always necessary because you need it for endometrial progesterone. Oral macronide progesterone, which is the bioidentical progesterone, is considered a safe alternative. At the dose of 200 milligrams daily or 100 milligrams daily. And this with a 0.025 patch is effective to protect endometrium when it's given at 100 milligrams. When the dose is 100 milligrams. What is the benefit of progesterone beside endometrial protection? Optimizing bone density. There are lots of studies now being published about them, and the bone density, bone health, on the improvement in bone density of patients with progesterone. It does help vasomotor symptoms, and this is why that lady, 41 years old with high estrogen, had vasomotor symptoms at night because she had low progesterone. Is amazing for sleep. So it's really, really good for sleep, and very often is one of the first things women report is an improvement in sleep pattern. It has a neurobiological effect, so it has a sedative and calming effect. It's very safe for the cardiovascular system, and it's very safe for the breast. Having said that, I have to admit that there is a very minority of cases that women that do not tolerate oral progesterone, and I never understood why. So very often it's just a case of trying and see if it's the right option. So that these other studies again on safety of progesterone. And now I just wanted to mention just in the oral contraceptive versus HRT. What is the difference? So oral contraceptive is not made from bioidentical hormones. They are synthetic hormones, much stronger than the bioidentical hormones. And why they're much stronger? Because they have to be so strong to block the ovulation process and to block those hormones coming from the brain that I show you in the slide at the very beginning. So they have to inhibit that cycle, and therefore they have to inhibit the ovulation by blocking the feedback. So they do provide hormonal replacement, but it's not a bioidentical hormonal replacement. And they do provide contraception because they're stronger compound. Hormonal replacement is some hormonal replacement are bioidentical, but before they're bioidentical, they do really match well with the female physiology, and they do not inhibit and block ovulation. So they're not a contraceptive. And this is important, especially for women that go into this early premature ovarian insufficiency at the early stage. They still sexually, and this is the situation where the ovaries start running out of eggs, but you can't exclude the natural pregnancy in this condition anyway. There is about 20%. So those women, if they want an oral contraceptive to avoid unwanted pregnancy, they may take the oral contraceptive pill. Again, it's individualized care, and you have to respect other women's choices. It's not a perfect hormonal replacement, but it may be useful for some women. And the other thing, in the UK is a very favorable option because they're free. the oral contraceptive is free in the UK, whereas if you take HRT, you have to pay. In the very long term, so I'm talking about, adult women, HRT, so the natural hormone replacement, is the one recommended to optimize bone health, cardiovascular health, control breast cancer risk, and control the risk of thromboembolism. HRT is a physiological natural hormone, already said. HRT is safe, and now the very recent study have shown that is very safe also for the breast. And in relation to thromboembolism and stroke, so deep vein thrombosis and stroke, the transdermal estrogen, not progesterone, estrogen, is extremely safe. And is the first line treatment for women with high BMI or with a history of thromboembolism. Estrogen, now we talked about progesterone, and now we talked about the other hormone, estrogen, that is the one that you start replacing a little bit at the end of the perimenopause. The benefit that does correct vasomotor symptoms, does help with bone density, does help the cardiovascular system, and there are now evidences very important for cognition, and also for mood. Right, okay, estrogen can be given in tablet, in cream, in patches. In general, the patch is between 50 and 100 micrograms, but I would say that in perimenopause it would be around 50. Or there would be 2 milligrams equivalent of estradiol sachets, or the estradiol gel. Or 2 to 4 milligrams of oral estradiol. Generally is 2 milligrams. I think I would stop. Then I just wanted to mention, generally, the use of testosterone is indicated very often to help, again, muscle energy, energy, muscle mass, and libido. But again, I do prefer to use it when necessary, not at the beginning of when establishing HRT. I do like to use it at a later stage if patients are still complaining of a loss of quality of life in terms of fatigue, in terms of libido. It's extremely important for libido, but it can be given very low dose, but it may have some side effect, because some women may present side effect like skin problem, spots or an unwanted facial hair. And some women are very sensitive to testosterone and they start losing hair. So this is another treatment that could be extremely effective, but I think it has to be used at a later stage. But I think there's quite a lot to say about testosterone. I think as I said, some women have a different, do tend to metabolize testosterone in a more active form. And there are tests to identify that. So I would say very often it would be useful to do this assessment before, or maybe at the very beginning you start testosterone, so that you understand how the person is metabolizing testosterone and if the person is particularly susceptible to testosterone. Vaginal estrogen is important to address vaginal symptoms, so vaginal dryness, and to avoid the risk of vaginal atrophy. And they're very effective and risk-free for most women. And then there is this, the DHEA, I thought just to mention, is an androgen precursor, and is also quite good for energy level. DHEA get turned into estrogen and testosterone in the adrenal gland. Again, this is one of those hormones that could be really good for energy, but it could, for some women, could be a little bit tricky for the sign for signs of hyperandrogenism. So for some women can still present with the skin problems or hair loss following DHA. But yes, androgenic, clinical androgenic side effect. Okay, now this is about the breast cancer risk, but maybe I'm not sure if we want to talk about after the discussion, because I think a very common question is HRT a problem? Is estrogen replacement increasing my breast cancer risk? And I thought I just wanted to show you the very latest evidence on the topic. So breast cancer risk in women age 50 to 60 over the age of 5 years has been estimated. That means from baseline, and then you study this group for 5 years, you will find that 23 on 1,000 women in general not taking HRT will develop breast cancer. 27 women taking estrogen and the progestogen, which is not the bioidentical progesterone. This is the compound that is similar to progesterone, but it's not progesterone, will interact with the progesterone receptor. Then the risk is slightly increased. It's 27 over 1,000. Now, estrogen only, subjects taking estrogen only, those are women with no womb that are not taking progesterone. And then is actually estrogen is protective. So this is the new research. They show that estrogen is actually protective. But on the other hand, we also need to keep into account that overweight would increase the risk on 47. This is women not taking any hormonal replacement. Overweight will increase up to 47 to 1,000. Alcohol drinker to 28 to 1,000. Smoke to 27 to 1,000. And physical activity will decrease the risk down to 16 to 1,000. So as I said, when we do have to evaluate risk and stratify the risk, we need to think about the benefit of HRT and what is the actual risk of taking breast cancer. So we need to balance the risk and the benefit. And we also need to balance other risk factors for breast cancer. So yes, we do not want to take HRT, but what are we doing for weight? What are we doing for physical exercise? Are we smoking? So again, this is another element to highlight the importance of individualized care. And then I just wanted to say, this is another, I'm not an expert on this topic, but this is the latest information. So what do I do if I had the breast cancer? First of all, we know that there are those breast cancer that have a higher expression of the estrogen receptor. So this is one of the, one of the parameters that get evaluated. It has been noted that the women on with breast cancer and estrogen receptor positive taking estrogen do have a faster progression of the disease. Having said that, many oncologists point that this condition, beside taking or not taking estrogen, is extremely aggressive. So the community is still unsure about the effect of estrogen replacement on this kind of breast cancer. So this is a woman with active breast cancer. But I just thought to mention that because, again, this is another area that need to be evaluated and individualized. in terms of action plan. And I think this is the end of my presentation. Yes, I don't have anything else to add. Thank you for your attention. Thank you for your patience.